Okay, well, we've moved over to 10 o'clock, so we are going to get started. We have lots of information to go through today, folks. So thank you for joining us. My name is Jean Alton, and I'm a dementia care consultant with Alzheimer's San Diego. And I am going to be co-presenting Dementia 101 today together with my colleague, Amy Abrams, who is our Director of Education at Alzheimer's.
Good morning, Jean. Good morning, everyone. Happy to be here.
Hi, Amy. So, and we've got some other folks that'll be joining us, and we'll get to them in a moment here as well, too. Okay, so here's our agenda for today. So we're going to be talking about all these different areas of Alzheimer's disease and related dementias, what those look like, what are the symptoms, what are the similarities, what are the differences, how do you know what's what. We're going to talk about the risk factors for developing a type of dementia. How do we get screened? How do we figure out what's going on here? And how do we actually get a diagnosis of Alzheimer's disease or dementia? And then we'll talk a little bit about disease progression and symptom management. And then we're going to wrap up with some planning for the future with regards to concerns of safety, well-being, and support. So this is all just basic it's foundational knowledge for all of you folks who are here with us today to just get that good grasp about the basic information about Alzheimer's disease and dementia, so that you can then build on your knowledge from there and have a better idea of what are the things I need to be thinking about, or we as a couple or a family need to be thinking about in terms of planning for the future. So we're going to start with Alzheimer's disease. And did I just scoot ahead once? Too much? Alzheimer's disease and related dementias. So look at all these words here, all sorts of different words. And this is what we see in real life, folks, when we're talking with health professionals like Amy and myself, and with doctors, and in the information we're reading about, in the news and in websites. We see all these different words. And there's just a variety of language and terms and descriptions. And there's also a variety of context around each of these words. So we want to try today and just make it a little bit clearer and make a little bit better sense out of it for you. So we're going to start with just some terminology, some definitions. So what we're going to start with here is mild cognitive impairment, also sometimes called MCI, and also a little bit more frequently than before, called minor neurocognitive disorder. How many of you folks have heard MCI, or mild cognitive impairment? So MCI is its own diagnosis, okay? And it is diagnosed when a person is experiencing memory or cognitive change. It's not sufficient to affect daily activities, but it is more severe and or more noticeable than what we would define as normal age-related changes. In other words, the changes in memory and cognition are enough so that it is noticeable to either the person themselves and or to others that are around that person. Enough so that they're saying, really, there's a lot of memory change going on there. So that's how mild cognitive impairment is defined. And again, I just want to say it is its own diagnosis and is different from Alzheimer's disease. Okay, so, and then we've got this word dementia, and I always kind of feel like I have to throw actually ourselves as health professionals under the bus a little bit with this one, because we use this word probably more loosely than we should. And this is true when we see it oftentimes used in, again, social media and online. Dementia is a word that gets used a little bit more loosely than perhaps it should. What is dementia? Dementia is a syndrome, and it is a syndrome that describes a group of symptoms that are being caused because of some medical condition that's going on. And it's affecting these different areas of function: memory, language, visual perception, problem solving, and attention. All those areas can be affected. It is a diagnosis of dementia, which I'll come back to, is made when a person is experiencing changes in memory and cognition in two or more of these areas that I've just mentioned: the memory, the language, the sensory perception, and the executive function of being able to problem solve. Two or more areas, and enough so that the memory and cognitive changes are significantly affecting day-to-day life. Now, there are many types of dementia, and there are both reversible and irreversible types of dementia, and we will come to that. So, Alzheimer's disease. So this is the one term that, probably most of us are fairly familiar with. And Alzheimer's disease is its own diagnosis, and it is an irreversible and progressive brain disorder. And it is the most common cause of dementia. And we'll explore that a little bit more as well too. But again, the important takeaway for you folks is I want you to realize that there are many different types of dementia. So it's important to know what type of dementia it is that you're dealing with, and as best as can be done. And it can be done pretty well. Our diagnostic process has come such a long way just over the course of my career. I see this, and Amy, you will have too. And so when we talk about diagnosis, that will hopefully help it gel for you as to why knowing what type of dementia a person may have is important. There's also a particular type of dementia that we call young onset dementia. And this is when dementia is affecting a person at a young age, usually between their 30s and mid-60s, when they are diagnosed and or symptoms first appear. So oftentimes it tends to be in, I'm going to say, about the 45 to 60-ish range. But we have seen people in their 30s diagnosed with younger onset dementia. And so the age range really is 30s to, let's just say, 64. At age 65 plus, we're calling it older onset dementia. So for the folks with younger onset dementia, just a note that there's some very particular concerns for them, as you can imagine. They may still be in the midst of their careers, so these are the days of still earning money and planning for retirement, so this is a big change in life. There may still be children at home, either younger or college age. It's all sorts of really quite dramatic changes in a person's life when diagnosed with younger onset dementia. So it requires some careful planning and consideration. So here we go. There are many treatable causes of cognitive changes. And so this is kind of the first lead up as to why screening and eventually diagnosis is important. So what are some of the things that can cause cognitive change and change in memory in a person? Well, depression, for sure. For any of you who either have personally been impacted by depression or have a family member who's been impacted, you think about the cognitive and memory changes a person is experiencing. There's foggy brain, there's poor memory, there's lack of initiative. All these things are symptoms that are also symptoms we see in a person with dementia. Having any kind of an illness or infection of some kind or a medication reaction for sure can cause some sometimes significant and kind of awful changes in a person. If you've ever been really sick with all sorts of different things. I'm thinking, I'll tell you folks, a couple of weeks ago, I got really sick with food poisoning, is what I believe it was. And oh my brain went to mush during that whole thing. So there's, all sorts of illnesses and infections that can really impact our cognition. Any kind of dehydration or malnutrition is absolutely going to affect us. And I think of everything from, those, I haven't seen any for a while, but those funny commercials about people being hangry, you're not yourself until you have a Snickers. People get snarly and annoyed and irritable when we're hungry. But then I also even just think about, I don't know if any of you have ever watched but I'm sure you would have heard of some of those shows, those survivor type shows, and people that are going without appropriate, food intake and water intake over a period of time, their cognition quickly deteriorates. And so that's something for us to think about. Are we in survivor situations? Well, some days it feels like it. But, look, right now, and as we do this, I'm going to have a drink of water. It's, sheltering in place has changed our routines. And I'll tell you, with hydration, is I personally am not drinking nearly as much water as I need to be. And, that's easy for us to do. And it's even more easy as we get older, because our perception in terms of our ability to recognize that we're feeling a little bit dry or dehydrated is changing. So make sure you folks drink your water. Having inadequate sleep and experiencing stress, these all affect our cognition. And I don't think I need to explain that. We all know what it's like when you haven't had a good night's sleep. You've got fuzzy head. And then sensory loss can affect cognition. We had a absolutely fascinating webinar yesterday that Amy hosted, and we had a speaker who was an audiologist, Dr. Illich. He came in and talked about hearing loss and the connection with cognition there. And hearing loss is just one of the sensory losses that we know can really impact cognition and memory. So, important. Going back to what I said about the word dementia and how we use it perhaps a bit more loosely than we should. Dementia is not a specific disease. There are several different types of dementia. And some of the ones that are more common are Lewy body dementia, vascular cognitive impairment related to the heart health and the cardiovascular health. There are frontal temporal disorders, meaning it's affecting the frontal lobe of the brain. There are mixed dementias, meaning 2 or more types of dementia, and there are others as well. However, please note here we see how the pie is divvied up, that 60 to 80% of dementias are believed to be caused by Alzheimer's disease. So a little bit about Alzheimer's disease. If you were not aware of it, the disease itself was named after this gentleman, Dr. Alois Alzheimer, and he was the one who discovered it in this particular patient, a lady, Auguste D. And she presented with all these very unusual symptoms that nobody could really figure out what was going on. And he wasn't her doctor, but he was very interested in the case, and he followed it for some time. Auguste D died at a very young age, and Dr. Alzheimer requested of Auguste's physicians if he could do a brain autopsy to have a look at what was going on in her brain. And when he did that, what he discovered is what you see on the bottom here of your slide, is these beta amyloid proteins that are, we call them plaques, and these other proteins, tau proteins, that we call tangles, so plaques and tangles. And the plaques are forming between the brain's nerve cells and it just interfering with their ability to communicate and function properly. And then the tangles are actually forming inside of the brain cells. And so again, that's disrupting function. So all sorts of challenges going on for the neurons, the brain cells, to be able to function the way they're supposed to with this plaque and these plaques and tangles going on. So how is the brain affected then by the plaques and the tangles? Well, if you look at this graphic, you'll see on your left side what would be a cross-section of normal brain tissue. And on the right side, a cross-section of Alzheimer's brain tissue. And you can see the vast differences. And, you know, the normal brain tissue is, you know, I kind of like to say it looks like cauliflower. It's kind of all nice and clumped together. It's full. You know, it looks healthy. And plump, I guess, is the word I'm looking for. And we look at the Alzheimer's brain tissue, and there's been atrophy. It's shrunk away from each other. You can see the gaps there in the graphic. And I want you to have a particular look at the big gap kind of at the bottom there on the Alzheimer's brain tissue side. And that would be in the hippocampus area, and the hippocampus is just a super important organ in our brain for memory, for our brain's ability to be able to take information in and you know, kind of divvy it up in terms of what are we going to keep as short-term memory, what are we going to put into long-term memory, what's just working memory. So we can see there's just some real vast differences in between the two brains, and this is because of the plaques and tangles and the damage that is happening to the brain tissue. Oh, see, I forgot about that. There it is. There's the arrow showing the hippocampus in that now empty area. So that's where the memory is really being affected by Alzheimer's disease. It's important, though, to know that each type of dementia affects the brain differently. And so this is just kind of a quick overview of the different lobes in the brain. And, you know, so for example, the temporal lobe, which is the green part of the brain here, and by the way, it's not green in real life. This is where the hippocampus is living, in the temporal lobe. So a very important area. The frontal lobe, this orange part of the brain here, is, you know, where we have our executive function, where we make, you know, we do that important problem solving and decision making, where we have the ability to use reasoning and good judgment and have empathy for others. In the parietal lobe, this is where we've got our sensory perception is being made sense of. And word and thought formation is occurring here as well, too. The occipital lobe, the yellow part back here, is, you know, directly connected with our eyes. So this is the part of the brain that's helping, you know, working with our eyes to make sense of what it is we are seeing. And so, again, different types of dementia may affect different areas of the brain. When I made a reference to frontal temporal dementias, that's generally that we're seeing the damage to the tissue in the brain is starting in the frontal lobes for those folks. So that was a brief overview of Alzheimer's disease and related dementias. So we're going to give that a check off of our list. And I want you to, again, just be kind of keeping track of your questions and sending those in Q&A for us. And, you know, we'll devote some time to answering some questions here shortly. So we're going to move on. And now here's maybe some of the really important stuff for all of us. How do we know what is normal age-related change, and how do we know what are the symptoms of dementia? And these are the burning questions for all of us. These are the things we get lots of phone calls about. And if we, pre-COVID times, if we were presenting in person or any kind of conferences, this is the thing people really want to know. We all do, right? Well, first of all, a symptom of dementia is going to be something that involves a marked change for that individual. Now, we're talking about baseline. So for example, what my baseline is and what Amy's baseline is could be two quite different things. How so? Well, maybe Amy, and in fact she is, I know this, she's very knowledgeable and gifted with words. So any kind of word test, she may do much better on than I would. Another example I can say about me is, and I often use this, my working memory is really poor. And by that, my best example is if you tell me your phone number, I'll get the prefix right, the first three numbers, and then you'll have to repeat the last four numbers for me. So, my working memory can only capture 3 out of 7 items. And that's normal for me. That's always been the case. And so it's annoying, but it's not a concern. Now, if I had always been able to remember the full series of numbers for all sorts of different numbers over the course of my life, and all of a sudden I can't do that, that's a change from my baseline. So we have to look for a change from baseline, but clearly previous to that, we have to figure out what our baseline is. Symptoms of dementia are going to be significant enough to interfere with daily activities. How many of you folks lose your keys or your cell phones on a regular basis? I'm going to suggest there's probably quite a few people that do, and I certainly am amongst them. That's an annoyance, but it doesn't really interfere with our daily activities because, look, we almost always find them, right? Because we're able to retrace our steps. So we're talking about the kind of changes in cognition and memory that is significantly affecting our day-to-day routines. So, that's it. It's got to be fairly severe in order to be doing that. And then I want you to think about the 4 primary domains of memory, thinking, physical, and behavior. We experience changes as a part of aging in all of these areas. There are some memory changes. Again, might be, we're just a little bit slower to kind of pull up that information. How many of you have done that? It's like, well, I talked to, oh my gosh, what's her name? I talked to her yesterday. You know her. And, you describe the person and you can say what the person does for a career and where they live, and you can give all sorts of details, but you can't pull the name up. But eventually you get it, okay? So that's an example of an age-related change in memory, but memory change associated with dementia is more significant. And so these 4 domains are being impacted by dementia. And let me just note, memory is not always a symptom of dementia. Sometimes there are some people diagnosed with dementia whose memories are still pretty good. And that may be with a different type of dementia, where memory, that hippocampus area of the brain is not being impacted so much. So that's kind of the summary of age-related change versus symptoms of dementia. And again, the significant parts being it's a change from normal for that particular individual, enough to interfere with their daily routines. And it's happening in 2 or more of these primary domains of memory, thinking, physical and behavior. So a little bit more detail here in terms of what does this look like. I kind of went into this a little bit. Memory, again, you know, we have those challenges, bringing up the name of a person, or yes, losing the cell phone and the car keys or whatever it might be. But we're able to retrace steps and go back in our memory and come up with that information. For folks with dementia, it is more significant. They may be getting lost in their own neighborhoods, in areas that they've always been very familiar with. They may be forgetting the function of some objects, having challenges with that. With thinking, our normal age-related changes is that it takes a little bit more time for us to learn new things or solve problems. And we do have changes in attention or concentration. An example of this for me is if I'm reading, and it's kind of a combined example because it also illustrates my poor working memory, is if I'm reading a recipe, doing a new recipe, I will have to go back and read the recipe multiple times. I'll read it and then I'll do maybe step 1 and maybe step 2, but then I have to go back and look at the recipe again. And it's a combination of poor working memory, but also that I'm slower to learn new things and kind of keep that attention and concentration so that I'm able to, you know, continue on. I mean, I have to go back to the recipe for further direction. For folks with dementia, they're going to have new difficulties with any or potentially all of these things at some point: language, reading, writing, or working with numbers. And I will say it's oftentimes we see working with numbers is where this starts, because we may see people having problems keeping track of their finances and either forgetting to pay bills, or I had one client I worked with, she was paying bills twice over, and they were it was actually health insurance. So and it was through Cobra. So it was large amounts of money. And she would discover that her account was in the zero, was in the red. And she discovered that she was paying Cobra 2 or 3 times a month. Usually we hear about bills not being paid, but in that instance, she was overpaying. We see changes in judgment, insight, or reason. And, you know, this is why our folks with dementia are at high risk for all the crazy scams that are out there, and can be easily coerced and talked into things that they, given 10 years earlier or given a brain without dementia, would not have done. Physically, we all know we have age-related changes, right? We've got changes in our vision and our hearing and other sensory loss. We are less flexible and have less strength, and just, you know, all sorts of different changes are going on in our bodies that we are having to accommodate to. That's just part of aging. For our folks with dementia, there can be some significant changes to particularly the visual spatial field, but other sensory processing as well. And this can lead to, and often unfortunately does lead to, problems with balance, coordination, and more frequent falls. It tends to lead to problems just of a safety type because of the changes that they are experiencing. Behavior-wise, well, normally, you know, unless there's some kind of diagnosis of some kind of mental disorder, mental illness of some kind, changes in behavior are not a normal part of our aging process. It's kind of, we are who we are, and that doesn't change much really over time. But for folks with dementia, there can be some significant changes in behavior and personality. And it can be, I've seen it everything from actually a not so pleasant person becoming very pleasant. There's also been the other, where somebody who's always been a really lovely person has become angry and combative and, resistant to care. We see social withdrawal oftentimes and difficulty initiating new tasks, again, very common. And then just these changes in normal daily routines. So these are the things that we're seeing here. So that kind of is taking us through what some of the symptoms of dementia are. And so we're going to turn it over here to Amy, and she's going to talk about some other things, which are risk factors, screening, and diagnosis.
Can I get the remote control?
You sure can. As soon as I give it to you. How about that?
There we go. Great. Well, thank you, Jean. That was a great introduction to mild cognitive impairment, dementia more broadly, Alzheimer's disease, and the common symptoms of dementia that we see. So I'll talk a little bit now about risk factors. I am going to pause in a few moments for some questions. So please again, you don't have to wait until we're in the time for Q&A. Just go ahead, type those in if you have them, and we'll be getting to those in a few moments. So the impact of Alzheimer's disease and related dementias, you may see this written in either academic or popular literature as ADRD, sort of shorthand that a lot of us in the field use. We're talking about Alzheimer's disease and related dementias. The impact of these conditions can really not be overstated. At the latest numbers that we have indicate that nearly 6 million people in the United States are living with Alzheimer's or some other form of dementia. Age, I'm going to talk about risk factors here in a moment, but age is the primary risk factor. So currently 1 out of 9 people in the US who's over the age of 65 is living with some form of dementia. And those numbers, that percentage of the population just goes up as people age. So here in our county, in San Diego County, we are significantly impacted. There's nothing about San Diego County as a place or as people that makes us more at risk. It's simply a matter of demographics. This San Diego County, it's a nice place to live. People tend to, once you've moved here, you tend to stay here, meaning you tend to age here. And so because age is that primary risk factor, our county is more impacted than your average county around the United States. So currently, at last count, we've got nearly 84,000 people here in our county, and that's just people that are diagnosed, of course. There's plenty of people living with symptoms without a diagnosis. Alzheimer's disease and all progressive forms of dementia are fatal illnesses, right? As Jean described very nicely, they're impacting the brain cells, and the brain is the control center of all of the essential bodily functions. So that is an important thing to keep in mind as we talk about symptoms and the progression of those symptoms. These are terminal illnesses. Alzheimer's disease is currently, depending on what data you look at, the 5th or the 6th leading cause of death in the United States. At any rate, it's up there. But here in our county, it's the 3rd leading cause of death, at least in people over the age of 65. And that's not just, a lot of people sort of ask the question, is that dying with Alzheimer's disease or dying from Alzheimer's disease? And we are talking about dying from the condition or complications from the condition itself. So a significant impact clearly on the individual living with the disease, their memory, all of those key cognitive functions that Jean has been talking about. This takes a toll, not only on the person living with the disease, but everyone around them, everyone everyone who knows them and cares about them. It takes a physical toll on care partners, and certainly it takes a financial toll. Alzheimer's disease, generally, we don't, as we'll talk about, we don't have medical protocols for the treatment of the disease itself. We've got some tools we can use, some medications for symptom management, but for the most part, the symptoms of Alzheimer's disease are addressed through non-medical support, right? Making changes in a person's environment, providing 24/7 supervision when the person needs it, having a companion to give a caregiver a break, someone to help with meal preparation or remembering to take those medications, or someone to help with that bill paying that Jean was describing is so frequently a problem for folks living with dementia. These are considered custodial services. These are not medical services, and therefore we don't have health insurance that helps us pay for those services. So these conditions tend to have a very significant financial toll on people as well. Why don't I do this? While we figure this out, I'm going to answer a couple questions. May as well. Let's keep it going, because I see that some good questions are coming in. So I'll start with, how do you figure out what stage a person is currently in? I'm actually going to cover that in a moment, but generally we use an early, middle, and late stage model at Alzheimer's San Diego. There are numeric sort of functional scale models of disease progression, but we keep it pretty simple, and we typically use a person's need for assistance with personal care as the kind of marker between, in the early stage, a person can manage all of their personal care, their basic daily care tasks totally independently. In the middle stage of the disease, they start to need some assistance, and that might just mean reminders, or it might mean I need some actual physical or verbal prompting to get through a task. And in the late stage of the disease, a person needs physical assistance with basic daily care tasks. What do you do when someone refuses to go to the doctor for any testing? A really terrific question, probably something that's on the minds of a lot of people. I would say start with screening, right? There are a lot of resources available for community memory screening. This feels a lot less invasive. It doesn't necessarily happen in a doctor's office. And it's something that two people can do together, which is a big bonus, being able to say, let's go get our memory checked, right? And it's a nice way to sort of open up the door to that process for a lot of people. Let's see.
Amy, do you want to give it a try now? I'm trying to work behind the scenes here.
I don't have remote control.
Gosh darn.
Sorry, folks. I'll keep going. I've still got more questions to answer. So, yeah, another really good, a related question, but maybe even more complicated. As a family member who lives with someone with Alzheimer's disease, if they're in avoidance or denial and they need help with these things that we're talking about, banking, scheduling appointments, getting the bills paid, food prep, decision-making, how can we support them or get them the help that we need? This is a complicated question, and I'll answer first just by saying this is what our social work team is here for at Alzheimer's San Diego. If you want to have, one of our dementia care consultants can talk with any of you one-on-one to kind of talk through your specific situation, to kind of get a read on what is the nature of that person's resistance. Often it kind of looks like somebody is avoiding the topic or they are in denial. But in many cases, a person who's living with dementia, as Jean was describing, when there's damage up in the frontal lobe of the brain, they actually don't have full sort of perceptive abilities. They may not actually have any insight to the fact that anything is changing with them. So they may not recognize that I don't remember what I don't remember. I also don't remember that I'm even having memory problems. So if somebody is trying to convince me to get some help, and I don't have any sense that anything is the matter with me, right? We need to have a very different conversation about bringing in help. So it comes down to, you develop a strategy for figuring out, where is this person coming from? How much insight do they have? What is the nature of their resistance to having that help? And then kind of shifting the way you talk about that help. So it's a very broad answer, because there is no one answer that works for everyone. But please know that is what we're here for. Our social workers can help with that. So there's another question here. If I feel they're having anxiety, obsessive compulsive disorder, can they get specific support? I think this question is about the co-occurrence of dementia symptoms and other mental health issues. And this is a really, first of all, I'll just quickly answer, yes, absolutely. There are mental health services and psychiatric services that are developed that exist specifically for people who are living with dementia. Here in San Diego County, we have a host of different very good geropsychiatrists. These are psychiatrists who specialize in the mental health needs of older adults, and many of them have some additional and specific expertise related to dementia. So yes, it does take some specialty care and some specialty services, but absolutely, if a person is living with dementia and they have other medical conditions, physical conditions, or mental health conditions, there's no reason that we can't treat. It does make treatment more complicated, but there's no reason we can't treat those symptoms. So,
Amy, I'm going to try this again. Let's just see.
Okay. There's another question here. Are there recommended places you can go for memory testing? Yeah, absolutely. Of course, in normal times at Alzheimer's San Diego, we do memory screening on a monthly basis at our office. That is not currently available, but there are several diagnostic clinics that are open and serving patients and clients here in San Diego County. So if you would, what I'll ask is, toward the end of the webinar, we're going to put out a link in the chat where you can request follow-up information. Just let us know that you're looking for memory clinics, diagnostic clinics, and we've got a PDF list of those clinics that we can send to you. But yes, things are a little different right now because of the challenges of providing face-to-face services, but there are definitely still screening and diagnostic testing services available. Oh, I really like this question. Does a person who's living with dementia know, or do they have a feeling that they're experiencing this cognitive decline? And why are there those good days and bad days? This is a terrific question. I mentioned before that often when there's damage in the frontal lobes of the brain, a person does not have insight. There's a name for that. That condition is called anosognosia. And it's very common in about 50% of people who are living with early stage dementia. They don't have any awareness. They don't have any insight. So very broadly, I would say about half of people don't have a sense that they are experiencing that cognitive decline. And so, it makes a lot of sense. They're wondering, what is everybody's issue? Why is everybody so concerned? No, I don't know why my car has so many scratches in it, right? Because they don't remember those incidents of hitting the mailbox or whatever the thing might have been. So yes, about half the time people do have some awareness, and about half the time they do not. So it's really important to us who are supporting those individuals that we figure out sort of where they are. And as far as why there are good days and bad days, it's just like any of the rest of us. Right? Jean was describing the extreme conditions you see on shows like Survivor, where people are not eating or drinking regularly or not getting a good night's sleep. But that's kind of a normal daily human experience for all of us, right? If I get a really poor night's sleep, you're going to know it the next day. If I haven't eaten and I'm hangry, or my blood sugar has dropped, you're gonna see a difference, and I'm gonna have a better day or a worse day, or a better hour or a bad hour, right? Depending on what's going on with me in terms of my fatigue levels, my stress, my overall kind of biochemistry, right? That's the case for all of us as humans, and it's no different for people who are living with dementia. So you have those brain changes that Jean described, but then those brain changes are also impacted by just generally, how's the person doing, right? How much sleep did they get? How much stress are they under? How well hydrated or well fed are they? So yeah, it's complicated, but yes, it's a really wonderful question. My family and I are considering moving my dad from a memory care facility into one of our homes. We believe he's in mid-stage. Are there resources to help us with this? Absolutely, there are. And this is something a lot of families are contemplating right now in the midst of the pandemic. We see a real uptick in people contemplating this very, very complicated and challenging decision. And yes, there are definitely resources. Alzheimer's San Diego, our social work team is happy to be a resource to you, to talk you through the steps, the things to consider. There are also private care managers, aging life care professionals who do this on a sort of consulting basis. You can hire them on an hourly basis. There are other case management services available here in San Diego County. Again, I'll encourage you, if you're looking for any of these resources, just fill out the social work support request form that we're gonna put out in the chat at the end of the program. We'll be happy to send you those resources. But yes, it's a dilemma a lot of people are facing right now. And let's talk a little bit about risk factors. I mentioned that age is the primary risk factor, certainly for Alzheimer's disease and for most types of dementia, but not all. Some forms of dementia do tend to impact younger adults first, more heavily than older adults. Being female is in fact a significant risk factor for Alzheimer's disease and, again, several other types of related dementias. About 2/3 of everybody who's currently living with Alzheimer's disease in the US today is female. So a statistically significant difference, although all of these conditions affect men as well. These health factors that you see listed here: hypertension, heart disease, diabetes, specifically type 2 diabetes, and hearing loss. These conditions are, there's a pretty good body of evidence that shows none of these factors are causal, by the way, but they are associated with having a higher risk of developing dementia. So if you have any of those conditions, or if you inherited risk factors for heart disease, hypertension, or type 2 diabetes, just know that it is important to keep those conditions under control and well managed. Your genetics and your family history play a role in your individual risk for developing Alzheimer's and other kinds of dementia, but are not deterministic. So we have identified a set of genetic markers that sit on the 21st chromosome that can tell us whether or not an individual person has a slightly higher or slightly lower risk of developing Alzheimer's disease, as one example. But no particular combination tells us you are definitely going to get Alzheimer's disease. There are some rare forms of genetically inherited dementia, but they are exceptionally rare. So typically we talk about family history rather than genetics. So if you have a first-degree relative, a parent or a sibling who has or had some form of dementia, you're considered higher risk. But again, it's not, in most cases, these are not inherited conditions as we typically talk about inheritance. Education: the lower a person's level of formal education, the higher their risk of developing dementia, as well as head trauma. A person who has sustained a concussion is at a higher risk of developing several different types of dementia. Most notably, we hear and read a lot about CTE, chronic traumatic encephalopathy, which is the form of dementia that a lot of professional athletes, as well as veterans who sustained head trauma in combat. This is the particular type of dementia that affects those individuals more heavily, but head trauma generally does increase a person's risk of dementia. And then Down syndrome is the last of the known risk factors. Individuals with Down syndrome are at an exceptionally high risk of developing Alzheimer's disease in midlife. So important to note, there are significant ethnic disparities here in the United States. African Americans and the Latino population have exceptionally higher, much higher rates of developing, risk of developing Alzheimer's disease and other forms of dementia than whites. This is related to, this is nothing to do with any genetic predisposition. This is about the disparities in access to healthcare and differences in those other health factors that are listed there on the screen. One thing I think it's really important to talk about is that if you look at this whole list here, you don't see any environmental risk factors. It doesn't mean there aren't any, we won't discover any, but at the moment, the research does not tell us that anything, in terms of pollution or the pesticide exposure or, anything in our diet or the water supply, anything environmental is causing Alzheimer's disease. But there's still plenty of research ongoing. Again, it's not to say we won't find that eventually. Okay, Jean, can you click ahead for me? Great. Okay, so what can you do to lower your risk if you don't currently have mild cognitive impairment or dementia, or just keep your brain as healthy as possible if you do? Something I always like to point out, I think we can feel very fatalistic about a lot of these conditions, but it's really important to remember that while, yes, Alzheimer's and other forms of dementia kill brain cells and impact function in all of those significant ways that we've been talking about, there's still billions of perfectly healthy brain cells in there. We want to keep them healthy and functioning as well as possible for as long as we can. So we have a whole other program on the topic of maintaining your brain health. So I'll just be quick here, but know that we've got other resources we can point you toward if you want to learn more about any of these in particular. But the bottom line of keeping your brain healthy, lowering your risk of developing dementia, and keeping your brain as healthy as possible is taking good care of your heart health. Right? So eating a good, healthy diet, the Mediterranean diet in particular is what's been studied pretty extensively and shown in some large scale longitudinal studies to have an impact on lowering an individual person's risk of developing dementia. Staying physically active, staying cognitively active, right? Continuing to have new experiences, meet new people, learn new things. Your brain needs novelty, right? So stay as intellectually active as you can, maintain social connections, easier said than done right now, but find ways to, have phone calls, exchange notes, have Zoom visits or FaceTime, whatever works for you. Have socially distant gatherings with friends or family if that's safe for you where you are, right? But social connections are absolutely important to brain health. We're primates, right? We're wired for making eye contact with each other and having social connections, and being isolated from each other is in fact, there's plenty of research that shows it's very bad for in terms of health outcomes overall, but specifically dementia risk. So maintaining one's emotional health, getting, if you have symptoms of dementia, depression or anxiety that are affecting your mood, that are affecting your sleep, that are affecting your ability to do any of these other things, right? That's going to affect your dementia risk. If you are up all night because of anxiety, or your sleep is disturbed because of depression, right? You're too tired to prepare and eat those healthy meals that you need to eat, to get the exercise and have do the social and cognitively engaging activities that your brain needs for you to do. So do maintain your, know the signs of depression and anxiety, and focus on getting a good night's sleep as best you can. Okay, can you click for me? Great. Okay, so we've covered this a bit. I'll be quick here, but getting screened regularly is really important. Jean talked about, the difference between the symptoms of dementia and things that are sort of normal age-related changes. Really, they're very person-specific, and so being able to tell whether or not this symptom that a person is experiencing is normal for them, or if this represents a change from baseline for them, requires that we know what baseline was. Right. So we strongly recommend that every person of any age, really, any adult, go ahead and get a memory screening, right? Kind of find out now what your baseline is. As Jean indicated, she has very poor working memory. It would be really important for her and her doctor to know that 10 years from now, right? If she's starting to experience some changes, you need to be able to see the difference between when I was in my 40s or my 50s and how I'm functioning right now, 10 or 15 years later. So memory screening, I think, is important for everybody, but certainly once you're over the age of 65 and you're moving into that higher risk category, having memory screening done on a regular basis is really important. And it is actually covered by Medicare. An annual memory screening can be done in your primary care physician's office if you want to. There are community resources for this, as I indicated before, but you can also do this through your primary care doctor, but you have to ask for it. Most doctors don't know to prompt you for that. So if you're a Medicare beneficiary, you do have a benefit for an annual memory screening. Right? So it helps us know what that baseline is or was for an individual person. It helps us detect changes early. There's been some great questions about, how will the person with dementia know that anything is going on with them? Well, as I indicated, about half the time they won't. So it's really important that somebody else kind of has a documented record of how my memory works, where my strengths are. I have a good versus not so good working memory, for example. If I've been getting routine screening every year since I, turned 65, then my doctor's going to notice it if I don't. Right? There's sort of a check and balance there. Allows us to detect those changes early. And if we detect those changes early, there are some significant benefits to that, right? It gives us the opportunity to engage in care planning. It gives people the opportunity to start having some of those important conversations, and it makes the medications that are available, which I'll talk about shortly, it makes those medications more effective. Also critically important, screening allows a physician or the screener to rule out remember Jean was talking about all of the things besides dementia that can affect a person's memory, right? That's a really important function of getting memory screening, is finding out, do I in fact have an undiagnosed and untreated depression that is responsible for these memory and cognitive symptoms that I'm experiencing? Do I have a thyroid condition? And do I have some kind of low-grade infection? And that's why I've not been sort of functioning at my best. This is where we start in the screening and diagnosis process. We kind of rule all that other reversible, treatable stuff out first. And as I mentioned, screening is available through primary care providers as well as community organizations generally. Okay, Jean, can you click? Great. So again, when we catch it early, we have a lot more options, right? Often getting a diagnosis is a complicated process. Any of you that have been through this can certainly attest to that. These are not easy conditions to figure out because there's so many different types of dementia. They all present so differently person to person. And we just don't have yet very good technology for looking inside of brains and looking at brain cells, right? So getting a diagnosis is a challenge, but once we have figured out what's going on here, we can target a more effective type of treatment. So, for example, if a person has this particular type of dementia, we may or may not want to prescribe certain kinds of medication with that, right? People with Lewy body dementia, just as an example, are far more sensitive to antipsychotic medication. So there's certain things that the doctor, the pharmacist would want and need to know in formulating a treatment plan. You do need to know what kind of dementia this is so that you can treat appropriately. We do have these medications, which I'll talk about, but they're far more effective if we start them when the person is very early in the disease process, while the brain chemistry is still only minimally changed by the disease process. The drugs can have more impact. And as I mentioned before, it just gives people more time to engage in that planning. And if you're interested in participating in a clinical trial, you have a lot more options available to you if you're very early in the disease process. Okay. Okay, so what happens during a diagnosis? There is no standard protocol for how this happens. We're working on it. We're working at developing better technology and helping doctors, primary care doctors in particular, have better tools for doing this. But at the moment, it's still a pretty haphazard is not the word I'm looking for. There's just not a standard procedure or practice for how this happens. Absolutely, we want you to start with your primary care provider because they're who knows you best. I mean, at least hopefully, theoretically, your primary care physician knows you best. So the person you have the best relationship with, that's the provider to start with. Primary care doctors can absolutely diagnose and treat Alzheimer's and other types of dementia if they've been trained to do so. Not all have, so you need to ask that question if you're not sure about that. They may refer you on to a specialist for either for a diagnosis or for a second opinion, or of course, depending on what type of insurance you have, you can seek out a second or third opinion as needed. So these are the types of specialists that you might see. A neurologist, of course, is a specialist in the brain. A geropsychiatrist, geriatric psychiatrist is that expert that I was talking about before who might be involved in treating a person who's got dementia as well as a mental health condition. But they're also often involved in the diagnostic process as well. Neuropsychiatry and neuropsychology, these are experts who really focus on the testing. They don't tend to treat patients on an ongoing basis. They tend to work in those diagnostic settings that I was talking about before. So these are the folks that will do the really intensive kind of cognitive testing if a diagnosis is not perfectly clear. And a geriatrician is a primary care, an internist, a general practitioner who specializes in working with older patients. And older, medically speaking, older means 65 or older. And geriatricians are few and far between. We don't have a lot of geriatricians here in San Diego County, but they do tend to be kind of de facto dementia experts because so many of their patients have dementia because of that risk factor that I was talking about before. So what can you expect during the workup? First, we start with that ruling out that I was talking about before, ruling out all those other possible reversible things that might be going on. So taking a medical history, doing a physical, asking for all kinds of lab work. Sometimes they're going to do a neurologic exam to, sort of do physical testing. That neurological exam may just involve reflex testing, testing your vision, right? Doing sort of in-office testing. It may also involve asking for brain imaging, right? MRIs, CT scans are the most common types of imaging that are used today, but PET scan technology is being used more and more. Neuropsychological testing is that work that the neuropsychiatrist or neuropsychologist does to kind of drill down and really see what specific issues is this person having, what types of memory and cognitive changes are most significant, because often they can tell, right, with all of this information, if they can physically look at an image of the brain and see where there's the most atrophy, and then through neuropsychological testing, they can see what cognitive domains are the most impacted. That will often help the doctor or the team of doctors kind of piece together the mystery of what type of dementia this is. A really important part of the diagnostic process is talking to other people for all of the reasons that you've all already brought up, right? It can be really hard for someone with dementia to accurately self-report what's going on with them. It's not always possible, but we absolutely encourage people to have an advocate in those appointments, somebody else to interact with the doctors and answer those questions as well. Okay, so I'm gonna skip. There was just one more question, at least that I saw. Jean, tell me if I'm missing something here. I see one more question here, but any social supports or resources for someone with dementia that lives on their own and would like to live on their own for as long as possible? Services that are available with Medi-Cal or Medicare. This is a really big question. And what I'll do is kind of punt it for now and just say, this is something that our social workers can talk you through. We have lots of resources at the office that we can talk to you about and send to you. But we do also have an education program on this exact topic. 2 classes in particular, I would point you toward our home care, daycare, and memory care class, where we talk about the different long-term care options that are out there, what they cost, and what benefits are available to help pay for them, as well as our legal and financial basics class, which covers this issue as well. I think that's all the questions I can see. Were there more? Okay, then we'll keep going. Great, let's talk about disease progression. Somebody asked a good question about this. So I've already given you the basic introduction, but here is visually what I was describing, that at Alzheimer's San Diego, we use this very simple 3-stage model. There's an early stage when the symptoms are mild, there's a middle stage when the symptoms are more moderate, and there's a late stage when the symptoms are severe. So you see, if you can see that image, right, there's no line at which a person is early versus middle versus late. It's a progression. It's not cut and dry like that. You'll also notice my handy dandy little chart here is missing numbers, right? How are we measuring function and over what period of time, right? It's really difficult for us to sort of guess and gauge where a person is and how long any individual person's progression will be. But as we've been describing, we are likely to see a long, slow decline over time, right? It's not common for there to be very quick moments of very steep, sharp decline in a person's function in the typical progression of most forms of dementia. You see that line is also not smooth, right? People, as we talked about, people have good days and bad days with dementia, just like they do without dementia. But over time, if we track a person's functional ability to do those basic daily care tasks, we are going to see a loss of that function over time. So we typically say, 2 to 20 years. It's really anybody's guess. That's almost a meaningless set of numbers, really, because there's so much variance there. The type of symptoms a person will have and how severe they will be is hard for us to predict. A very important point here, getting a diagnosis of Alzheimer's disease or any other progressive form of dementia does not automatically equal incapacity, right? There is a long early stage in most of these conditions. As we've been describing, this is a big reason that screening and detecting and finding these conditions early is so important. If we catch this disease early and you get that diagnosis very early in the disease process, you're very likely to have a good long period of time, in many cases, periods of years, wherein a person can absolutely still work, can engage in social or volunteerism activities, they can make decisions, they can get married, they can get divorced, they can buy cars and houses, right? They still have capacity to make decisions, but they may need some more support. So just the bottom line is that getting the diagnosis is certainly not the end of the road. So in the early stage of the disease, what are we likely to see, right? That short-term memory loss that Jean was describing, moments of confusion and disorientation, sort of not staying confused or disoriented, but momentary, periodic episodes of that. And as I mentioned before, starting to have difficulty with these, things like driving, paying the bills, managing one's own medication, following recipes, right, if they are familiar, those instrumental tasks, but not the basic daily tasks, right? Bathing and grooming and getting dressed and being able to eat and ambulate, right? Walk around. All of those things in the early stage, an individual is perfectly capable of doing those things if they were before, right? That's kind of baseline. In the middle stage of the disease, we're likely to see more memory loss, right? Not just short-term, but kind of more global, longer periods of confusion and disorientation. It's very common for us to see significant language changes and communication challenges in this part of the disease, just as the different regions of the brain, the pathology is spreading into different lobes and starting to impact the language center more heavily, very common. So this is where we're going to start to see the need for some help with personal care tasks. And again, it might just be a matter of reminders, or it may be, no, I actually need somebody to lay out the clothes for me, or to help me actually get my socks on my feet. This is the stage of the disease where safety becomes a paramount concern, because typically the person is physically as robust as ever, but what they've lost is some of that kind of safety awareness and judgment and insight. So the risk of wandering, the risk of household injuries, and certainly the risk of falling is much greater in this stage of the disease than it was at the beginning. And then in the late stage of the disease, we're likely to see very limited verbal communication, very limited movement, independent mobility. There's no two people experience the disease the same way, and so that's not universally true, but it's not uncommon at all. We absolutely need to plan ahead for a time that a person is going to require 24-hour supervision and assistance with all of those daily care tasks. Doesn't mean every person's going to get there, but it is something that we should, if we're putting together a realistic care plan, it's something we should be thinking ahead. We should be thinking ahead about. Not uncommon at all for people with dementia to have difficulty with chewing and swallowing. The back of the brain sends signals to our esophagus and tells us, okay, that which is coming down right now is air or saliva or liquid or food. And so it sort of determines where it should go, right into the stomach or into the lungs. Those messages get mixed up in people with late stage dementia. Can sometimes happen earlier in the disease for other people, but it's a common late stage symptom and something we just want folks to be aware of, to be thinking about, and, you know, as uncomfortable as it is, to be talking about it, right? Should the time come that we need to consider pureed diets or the insertion of a feeding tube or something, it's important that you have made your wishes known about what you want or what you don't want in that case. So be aware that that is not universal, but a very common symptom as well. Okay. But having said all of that, it is also very important that we pay attention to what abilities remain throughout this process, right? Yes, this is a progressive loss of function. There is a lot of loss here. There is a lot to grieve, a lot to feel sad and angry and frightened about, understood and absolutely true, but also be aware, right? Individuals with dementia can absolutely love, they can feel love, they can express love, they can make their own decisions, they can communicate their wishes, right? Without any words, I can tell you if I like what you're doing or if I don't like what you're doing, right? We as care partners sometimes have to learn some new communication skills, and that's what we're here for at Alzheimer's San Diego. We can support people with that. But through every stage of the disease, it's possible to continue to engage in the activities that you love. You may need to modify them in some ways, but we can stay connected to the people, the things, the activities that we love, the things that give us a sense of meaning and a sense of purpose. But it takes some thinking and some planning and some real learning and skill building in order to be able to do that. That's what we're here for. Okay. So on to the management of symptoms. As I said before, we do not have an effective form of treatment for Alzheimer's disease or frankly for any progressive form of dementia. But that's not to say we don't have ways of managing symptoms. Right, so there are 5 FDA-approved medications that help manage the progression of symptoms in people living with dementia. These don't treat the disease. They don't stop the disease process from occurring, but for many people who take them, what we will see is a delay in that progression. So if you think about that graph I showed you a few minutes ago, right, it kind of flattens that curve out for quite some time before we see that steep decline. We're very optimistic. We're going to have better drugs, more treatment options in the very near future. The research community is very optimistic about this. But at the moment, this is what we have. So we have 2 classes of drugs. We have our cholinesterase inhibitors. Aricept is the most commonly prescribed of these, but there are 2 others that are widely used, Exelon and Razidine. These are all the brand names. These are the drugs that I was mentioning before. They work better if we start them early because they work on acetylcholine in your brain. And so if we start them early before acetylcholine levels have started changing significantly in the brain, they have more of an impact. We'll see a more significant flattening of that curve in that sort of functional chart that I was showing you before. Namenda is the brand name of memantine, which is the other class of drug, a glutamate regulator. So this is a different drug and can be used in conjunction with one of these others. Aricept and Namenda are very commonly prescribed together. And for that reason, one of the drug companies got smart and put them together into one pill that's called Manzaric. This is just a combination medication. It isn't anything different. So these aren't great drugs. They're pretty expensive, covered by, many Medicare Part D plans, but they're expensive medications. And, again, they don't actually stop the disease process, but they are worth trying, right? They are what we have, and they are impactful for a good number of people who take them. So this is what it's all about, and this is really where we focus a lot of our education and support programs at Alzheimer's San Diego, is helping people adapt to this ever-changing, set of new normals, right? Every week, every day, every hour, sometimes it feels like we're functioning a little bit differently, right? What I'm able to do today may not be something I'm able to do tomorrow, but then that level of function may return the day after. So it's a constant kind of, I sometimes describe it as bobbing and weaving, right? Figuring out where you are right now and making the adaptations that you need to take. So there's a lot to this, and this slide is really just intended to tell you we've got resources to help you with all of these adaptations that we all need to make as a person with a new diagnosis or somebody who's caring for someone with one, right? Learning to communicate differently, to stop correcting people or getting into those same arguments. Oh, we already talked about this. I already answered that question, right? Learning to resist those impulses to just react to things, learning instead to kind of take a deep breath and really join the person where they are and respond to them. It can be done, it can be learned, but it takes some practice for sure, right? Learning what we can do to simplify the amount of choices we need to make during the course of a day, adjusting our expectations of ourselves and of other people, right? And certainly paying attention to the needs of care partners just as much as we're paying attention to the needs of the people living with the disease. So I'll skip over the rest of it for now, but know that there's lots of great resources out there for good, credible disease information. We're all about that at Alzheimer's San Diego. There's a lot of sort of garbage information, frankly, that you've probably already found floating around on the internet, advice that you get from people on Facebook, right? We really want you to consult with credible sources, and we provide those for you here. As Jean mentioned at the beginning of the program, we will be emailing this slide deck out to all of you. So you'll have this list of organizations and institutions and links to their websites as well. Okay, have any other questions come in?
There is one here that I just think is relevant to today's situation, and it is the pandemic allowing people who are living with dementia in facilities and memory care facilities? Is it contributing to a more rapid decline because families can't visit? They have, they can't go out on community outings, that kind of thing.
This is a terrific question. The data is still very early because, of course, while it feels like it's been a million years that we've been living in this pandemic, it really has only been 5 months. So there's not a lot of data out there yet, but there is some interesting data beginning to be published. We actually just put out on our blog, on Alzheimer's San Diego blog. So visit that, it's on our website. We put out the results of a very recent study put out by, I think it was Pitt. I don't remember which university it was, but yes, the short answer is the data is still early, but we do see people are experiencing kind of faster decline when they are socially isolated. It absolutely has an impact. Yeah.
Good, thank you.
Sure.
Okay, so I'm going to jump in and just talk a little bit about planning for the future and covering all these areas of safety, well-being, and support. And there are many safety considerations to have on your radar when somebody that you live with and care for and care about has been diagnosed with dementia. And I want to tell you that we've got some really terrific classes, some very specific to these subjects that you see on this particular slide. And they're very important. And we want you to have this kind of in the forefront of your mind, because we want you to be proactive in terms of your planning with regards to safety considerations. And so falls are important, and we know many people with dementia do have falls because, again, of those changes that are going on in their sensory systems, and particularly with regard to the visual fields. It's important to be addressing injuries and potential for medication errors, which really is probably the one that you need to get onto right away in terms of having a plan moving forward. You know, medication errors can happen very easily, and especially if a person has an issue of memory loss. It's like, did I take the pills? No, I didn't, so I'm going to take them. You may, you know, have a person living with dementia taking medication several times over, or potentially not taking it at all. So having a plan to address medication errors before they happen is important. There is, of course, abuse prevention in terms of both the financial abuse that can go on, but of course, unfortunately, there are people that are, you know, physically isolating seniors and sometimes abusing them physically as well too. And additionally, what we would include in abuse prevention is the issue of self-neglect for any of our folks who are out there and living alone with dementia, and the changes in cognition and memory are resulting in some issues of self-neglect. Driving is its own class that we have, talking about driving and dementia. And folks, we all know it. We all have to be planning for the day. We do, all of us, dementia or no dementia, give up our keys. And it requires some special considerations for folks with dementia. It's not a black and white thing that, as Amy said, dementia doesn't, you know, equal incapacity. So a diagnosis of dementia today doesn't mean you can no longer drive. You're not safe to do it. It needs to be well thought out. Firearm safety is another big issue. We know that many homes in San Diego County have firearms in them. We're a military town, and you know, we've got lots of retired military and retired police officers and other people who are involved in services. And so firearms are there. And again, a well-developed plan needs to be figured out ahead of time proactively, so that we're not dealing with what has potential to be tragic situations. Caregiver stress is a very important safety concern for all of the care partners out there, because we know what stress does to the human body, and we need to really have some good plans in place for addressing those stress issues. And wandering as well is a big thing. I just actually got an alert here on my phone just about 15 minutes ago about somebody here in our neighborhood who has wandered and become lost. The majority of people with dementia, this happens to them at some point in time. So we do have some great local resources very specific to wandering. One is Take Me Home. This is a program through the San Diego Sheriff's Department. It's at no cost, and all, you know, it's easy to register your person who is living with dementia. And what this does is allows, in this instance, I just got this alert. If my person living with dementia wanders away from home, I call 911 and let them know I can't find my person, and let them know they're enrolled in the Take Me Home program. And that's when this whole system kicks in, that the Sheriff's Department coordinates with local law enforcement in your area to put the word out, just as I got here the alert on my phone, so that as a community and as for responders, first responders, they can be looking for the person who has wandered. Medical Alert Foundation is the one where you wear identification bracelet or dog tag. Also, there's clothing labels and other things, keychains, other items that can be on the person, excuse me, identifying them as being someone who's memory impaired. So this is another program that you can get engaged with as well. And Alzheimer's San Diego, we've got all sorts of referrals that we can give to you, referrals to GPS types of technology, everything from the simple to the complex, other resources as well too. We do also partner with a local gun range and weapons gear shop that we can provide you with gun locks for those firearms that are in the home at no charge. And you just need to give us a call or go onto our website and we'll be happy to get that information to you. So, you know, you have to prepare for the future. This is, as for you folks as care partners, it's going to take demands on all sorts of areas of your life. And so you need to shore up those areas as best as you can and grow them. So acquire knowledge and acquire skills to be able to manage the different areas of caring for a person living with dementia. Build your networks, and you know, we can help you to do that. And most certainly, folks, get some regular respite. And if you are having trouble doing that, please get on the phone to us at Alzheimer's San Diego, and we will help you to craft respite into your weekly schedule. Attend to your own physical and healthcare needs, and make sure as best as you can to maintain a sense of humor. So whatever you have to do that. Go watch the funny dog videos and cat videos and kid videos on YouTube. That's always a good way to get a chuckle and a smile out of the day. It's never too early to start the conversation. It's also never too late, but early is better to be getting those things in place, advanced care directives for, you know, for each of us as individuals, again, dementia or no dementia, to talk about safety and again, be proactive in planning for things so that we don't have to be reactive in a situation. Addressing the whole driving issue. Financial planning, very important because some of the care resources and the costs of care associated with that are expensive. So our budgets dictate lots of what we do in our lives, and that's no different when dementia becomes a part of it. So we need to look at the numbers as well too. Engage your support system. Don't just build it, engage it. Get people involved in your life and your lives to be able to provide you support. And again, maintain your health. Alzheimer's San Diego, we do all sorts of different things, such as these classes. And we are also on the phones Monday through Friday, 8:30 to 5. You can talk to a social worker at any point in time. Amy just sent out in chat a form that you can fill out, and that will be sent to our team of social workers, and you will get some follow-up by one of us at some point here soon with regards to the areas that you are most interested in receiving some information and or support about. We do all sorts of different things, and you can see in this particular graphic all the things that we're doing now here and have been, but right now this is all virtually. So since the pandemic and sheltering in place, and a couple of very interesting things that are going on is our Take Charge series. We've got a series coming up in the fall, and this is a series, a 5-week series of classes that are specific for people with a new diagnosis of some type of dementia and their family members and care partners. And you know, really what we do is we kind of cover Dementia 101 like we've just done, but in much more detail. And so if that's something that you think might be a good fit for your family, please give us a call and we can talk about it further and see if that's going to work for you. We also have a terrific virtual program called All's Companions. This is a volunteer-based program. Volunteers are matched up with families to have virtual social visits with the person with dementia. And we've got folks ready to, trained and ready to go in this particular program. And I always like to say, we've got folks from all over the country. And in fact, I think we've got some people from all other countries, so all over the world, participating in this program as volunteers for San Diego families. So we're very proud of it. We've got these volunteers. If this is something good for you folks, give us a shout. And as always, there's our website that you can go to. Please have a look at our webinar library. We've got lots of our past classes posted there that you can have a look at. And of course, have a look at what we have upcoming for classes, because we just gave you a little touch and a little taste of everything here today. We do encourage you to continue to attend our classes. And give us a call as well. And again, there's that follow-up request form that you can see in the chat box, the link to that. And so that, I think, brings us to a close. We do ask for your feedback. You will be sent a link to an online survey that we would like you to fill out for us and let us know what you thought of today's program. And you can go ahead and feel free to tell me to improve my Zoom webinar skills. And I can assure you, I will seriously be working on that. So please take a note of our upcoming programs. Next week, we have communication skills for care partners. This is a terrific class. Everybody really should take this one. This would be a class I would say is a must for all of us. And then we have safety at home coming up. We're presenting with Elder Help on that. And we've got a whole bunch of other good classes coming up here in the fall. So thank you